My topic is complete versus target vessel revascularization in acute coronary syndrome. So I'm going to present a case so that we can understand the controversy behind this topic. That a 48-year non-diabetic, non-hypertensive, non-smoker male presented with a typical retrospinal chest pain with sweating since last 4 hours. In his echo, the LAD territory was hypokinetic and EF was 30%. And patient was hemodynamically stable. And this was the ECG showing the acute anterior MI. And this is the still image of the this patient of the angiography. And you can see there is a LAD, ostial LAD 100% thrombotic, and the RCA in the mid is 70 to 80%. So it is clearly seen, we know everything that primary PCI for patients with STEMI reduced mortality and myocardial infarction. And 45 to 60% of primary PCI patients have multivessel coronary artery disease. So those patients with the multivessel coronary artery disease and STEMI have worst prognosis and higher rate of mass at 1 year. So the LAD stenting was done immediately. The controversy behind is that what to do for the RC. There are 4 strategies which we can adapt. The first strategy is PCI to LAD only, in which the culprit only PCI. The LAD was stented and the patient was sent on home with the medical management of the right coronary artery. Second strategy is that PCI to RC along with the LAD. So at the time of primary PCI to LAD, RC was stented. And this is called the immediate complete revascularization strategy. Third strategy is PCI to RC in index hospitalization, in which the patient, the RCA is revascularized before the hospital discharge. And fourth strategy is PCI to RCA after discharge, and the revascularization is within the 2 months. So these are 4 strategies, and guideline did not clear about which strategy should be adopted for this RCA. So in 2013 ACC guideline, the non-infarct related artery revascularization class 3 indication in ACC guideline, and there are from 2009 to 2019 there are 10 randomized studies were published which address this issue. The first study is that HELP AMI 2009, and this study showed that multivessel PCI at the time of index procedure was not associated with increased in-hospital adverse events. And the next trial was the Polity 2010. This was the randomized trial, and this trial has shown that the 60% reduction in the mass event in complete and stage revascularization arm compared to complete culprit only arm, and there was no significant difference in overall survival. And the primary trial that was published in 2030, it is the immediate revascularization trial. It has 2 arms, preventive versus no preventive PCI. And in the preventive arm, those with the non-infarct related artery with more than 50% stenosis were revascularized at the time of primary PCI. And there was a 65% reduction in the primary outcome in preventive arm compared to non-preventive arm. And there was a 70% reduction in repeat revascularization in the preventive arm in this trial. So this trial has shown that preventive PCI significantly reduced the risk of adverse cardiovascular event as compared with the no preventive PCI. And the Dynamic 3 was published in 2015. It also reduced the mass event 44% compared to the infarct-related artery only. But the primary endpoint is non-significant in all-cause mortality and non-fatal MI. And the mass reduction is primarily from the ischemia around revascularization. So in this Dynamic 3 trial, the complete revascularization guided by the FFR measurement significantly reduced the risk of MS, but this trial failed to show an impact on the outcome like death and MI. So this for the the culprit trial was published in 2015, and the goal of this study was to determine whether the benefit of complete revascularization are sustained long-term and their impact on the heart outcome. And this is also an immediate revascularization trial. In this, more than 70% or more than 50% angiographic stenosis in 2 plane in the complete revascularization was done, and the total mass, there was 43% reduction in total mass in complete revascularization arm compared to IRA only. And the hard endpoint like death and MI, there was 53% reduction in the primary endpoint. So this trial has shown that there are significant lower rate of the mass is sustained over a median of 5.6 year follow-up. So basis on these guidelines, in 2015, ACC recommend the class 3 to class 2B indication for the non-infarct-related artery revascularization in STEMI patients. In 2017, a compare acute trial was published. The aim of this trial to investigate the FFR-guided immediate complete revascularization in comparison to culprit lesion treatment only strategy in the ST levels and MI. In this also, there was a 60% reduction in mass compared to infarct-related artery only lesion. But the culprit with this trial that the mass rate was completely not, there was no significant difference in the death of any cause and myocardial infarction between the culprit versus non-complete, complete versus non-complete revascularization. And there was no significant difference in secondary endpoint. So in this compare acute trial has shown that FFR-guided complete revascularization of the non-infarct-related artery in acute setting resulting in 65% reduced risk of mass, but without the effect in death and MI. So on these studies, 2017, ESC had changed the guideline from 2B to 2A for the non-infarct-related artery revascularization in the STEMI patients. In the last year, in 2013, complete trial was published. The aim of this trial whether the PCI of non-culprit lesion reduced the risk of cardiovascular death and MI. In this, the patients were included those with the primary PCI and at least one non-culprit artery amenable to PCI. And the primary outcome of this trial was the composite of cardiovascular death, new MI, and ischemia-driven revascularization. And in this, the non-culprit vessels should be at least 70% stenosis or 50 to 69% with FFR less than 0.80. And in stage PCI for all non-culprit lesions were performed within the 45 days of randomization. So this trial also showed that significant improvement in the co-primary outcome. And the co-primary outcome were the cardiovascular death and MI. There was 26% reduction in comparison to culprit lesion treatment only. And the key secondary outcome, there was 38% reduction in complete revascularization arm versus the culprit lesion only treatment arm. And there are also significant improvement in secondary outcome, but in the safety outcome, there was no significant difference in the major bleeding and contrast-associated acute kidney injury between the two arms. So this trial also, so you can see in this Kaplan-Meier graph that first co-primary outcome, there was 26% reduction in the complete revascularization arm versus the culprit lesion only PCI arm. And in secondary co-primary outcome, there was 49% reduction in the secondary co-primary outcome compared to culprit lesion only PCI. So these are all our randomized trial. In 2020, the systemic meta-analysis of these all randomized analysis was published by Yusuf Ahmed et al. In all 10 trial was randomized, and these randomized trial, these meta-analysis of the randomized trial has shown that cardiovascular death, myocardial infarction, and unplanned revascularization were significantly lower in complete revascularization arm compared to culprit only treatment arm. So, but the all-cause mortality and the major bleeding was non-significant in both arms. So, and as far as concerned about the impact of the timing of the complete revascularization, immediate versus stay, there was no significant interaction of the timing with risk of cardiovascular death. And as for we concerned about the FFR, there was also FFR guided revascularization versus angiographic guided revascularization. There was no significant interaction with the risk of cardiovascular death. So with all these randomized trial and this meta-analysis, the learning point is that there was a consistent treatment effect for complete revascularization versus infarct-related RT-PCI, regardless of the timing when the complete revascular was achieved. Hence, achieving complete revascularization rather than the timing of it is important determinant of the clinical outcome on the basis of the totality of the randomized trial data, and this analyzed guidelines should be updated to give a class 1 recommendation for the complete revascularization in the appropriate ST11 patient with multivessel disease. So all about my topic. Thank you.